The sonographic finding ultrasound is usually the initial study in patients who present with ovarian torsion. It is important to correctly identify the absence of torsion to allow conservative treatment. It is also very important to make the diagnosis as soon as possible so that the right surgery can be done. Early diagnosis is crucial, and what is accustomed to do in premenopausal women is to untwist the vascular pedicle despite necrotic appearance of the ovary at surgery, and 4 to 6 weeks later return to surgery after the hemorrhage and edema has resolved. In postmenopausal women who are less likely to get ovarian torsion, usually this treatment is oophorectomy. The sonographic findings of ovarian torsion include a large ovary, I mean, 23 to 44 cubic centimeters. The ovary can be echogenic with multiple small cystic areas aligning in the periphery. Right ovary is more likely to be involved because they feel that the sigmoid on the left protects the left ovary. You may see a coexistent cystic, solid, or complex mass in 73% of the cases. It's less commonly seen in patients who have pelvic inflammatory disease, endometriosis, or malignant neoplasm. And this is due to in these cases, it's felt that these patients have adhesions, therefore renders the ovaries immobile to torsion. The identifications of absence of flow can help make the diagnosis. Occasionally, we'll see free fluid, and identification of the twisted vascular pedicle can be very helpful. Comparing with the contralateral side is crucial in making this diagnosis. Even though that identification of absent flow in the ovary can help you make the diagnosis, that's only seen in less than 50% of the cases. And the reason is that the ovary has dual arterial supply. So you may see flow within the ovary and still have ovarian torsion. As you can see in this study that was done, absent arterial and venous flow was seen in 40% of the patients, but you could see normal arterial and venous flow in 7% of the patients. So there's a whole variety of flow patterns that can be seen in the presence of adnexal torsion. But even though the colorful Doppler is highly variable in patients with torsion, the absence of arterial blood flow is still seen in a significant percent of patients. Normal flow is seen in 60% of patients, and that's due to the dual arterial supply, and probably that due to venous thrombosis occurs before arterial obstruction. Absence of reversal diastolic flow has been described in these patients. Most frequently, what we will see is either decrease or absence of venous flow first, and this is felt to represent a collapse of the venous wall, which probably occurs before arterial compromise. A color flow Doppler in ovarian torsion, the presence of flow does not allow exclusion of torsion, suggests that the ovary may be viable, especially the flow is seen centrally. Absence of flow in a twisted vascular pedicle may indicate that a not viable ovary. CT may even help when ultrasound findings are ambiguous by showing nonspecific lack of enhancement in a midline mass, and possibly gas within the mass. Deviation of the uterus to the side of the affected ovary is frequently seen, associated with ascites, thickened fallopian tube, and obliteration of the planes. And here's a case of an ovarian torsion. On the left, a normal ovary showing flow within the ovary. On the right, markedly enlarged ovary echogenic center, and you can see in the periphery multiple cystic areas in this torsed ovary. Very important to compare one side from the other. Ovarian cancer is the most frequent cause of death from gynecological malignancy in the United States. 20,700 new cases per year are seen with ovarian cancers. 16,000 women will die with this disease this year. 1 in 17 women will develop ovarian cancer, which is less frequent than in breast cancer, which is 1 in 8. The problem is that usually by the time the patient presents, the tumor is advanced. The symptoms become apparent when the tumor compresses or invades the adjacent structures, ascites develops, or there's metastasis. 70% of these women will present with advanced disease, and therefore the 5-year survival rates in these women is 15 to 20%, compared to stage 1, which is up to 90%. And here you can see on your left a transvaginal study showing a large complex mass, solid and cystic components. Doppler shows low resistant waveform, increased diastolic flow in this postmenopausal woman with an adnexal mass. Postmenopausal women should not have a low resistant wave, increased diastolic flow in any adnexal mass. Another patient, and this is to show that morphology is the most important thing. This woman presented with a complex adnexal mass. Postmenopausal woman the mass had a solid component that had flow, but the flow within it was a high resistant flow. But the morphology is more important than the waveform. This was cancer until proven otherwise, and it was an ovarian carcinoma. Metastasis to the ovaries can also present, and it's seen in 10 to 30% of ovarian malignancy. Most are postmenopausal females. Most common is from adenocarcinoma of the endometrium. But metastasis can also come from the breast, gastrointestinal tract. 30 to 40% present with bilateral adnexal masses. And metastasis can also be due to lymphoma or leukemia. And here's a case of an enlarged ovary in a postmenopausal woman. No mass was seen, just the ovary was enlarged and had low resistant waveform with increased diastolic flow. This is abnormal. This was metastasis due to an adenocarcinoma of the endometrium. Echogenic free fluid in a premenopausal woman may be due to ruptured hemorrhagic cyst, pelvic inflammatory disease, or ectopic pregnancy. However, in the postmenopausal woman, when you see echogenic free fluid, you have to worry about malignancy, even though you may not see the primary. Pelvic pain can also be due to non-gynecological abnormalities, and these can arise from the bladder, urethra, ureter, bowel, or adnexa. In the bladder, a patient can present with pain due to cystitis or infection. Cystitis can be due to infectious cystitis, interstitial, or radiation cystitis. These women can present with severe pelvic pain. The predisposing factors of infectious cystitis are various. And here are two different patients with cystitis. On your left, you can see a distended bladder with echogenic material and some echogenic foci representing gas. This was infected fluid within the endometrium, within the bladder. On your right, another patient which shows a thickened bladder wall, diffusely thickened bladder wall, cystic areas within the bladder wall. This was due to radiation cystitis.